Hello, eGPlearners, learners. Welcome to this episode. Myself and Andy are going to be joined by some extra guests talking about the concept of acute hubs in general practice. This is the big news story from a couple of weeks ago, as we talked about, is it the end of general practice? But actually, this week, we're going to give you some of the information, some of the evidence, and some experience of how these may work. In addition to that, we've only got 1 month to go to the end of the financial year, so big stuff in terms of QoF and that kind of things. And absolutely, many of you probably realised the new GP contract dropped last night. So we will be talking about that. I will signpost you to our fuller episode that we're going to do on Saturday, just for me and Andy, but some proper time to digest it. But actually, let's get cracking as we start on this episode talking about hubs, end of the year, and GP practice. Let's get cracking, shall we? So, as you can see, I'm joined on screen by some extra guests, including Andy. First of all, how are we doing out there, Andy?
Yeah, do pretty good, Gandhi. It's really exciting to have some additional people with us to have a little bit of a discussion, debate around same-day access hubs. As you were saying, we covered this story about 2 weeks ago, and it generated quite a lot of feedback from people in the chat. Some people in favour of this model, some people feeling that it did as we sort of playfully build it. Does this mean the end of general practice as we know it? And some people were in that camp as well. So it obviously generates a lot of feeling in viewers and listeners. So it's great to get a bit of expertise in the room to talk about this in more detail.
Definitely. So probably worthwhile we introduce our guests. So I'm going to go around in screen order. So I went to Andy first. If I can go to Stefan next. So Stefan, feel free to say hi to the eGP learners out there.
Thanks, Gandhi. Hello, everybody. I'm Stefan Scholtes. I'm an academic. I work in the University of Cambridge as a professor of health management. And I also work very closely with Grantor Medical Practices in South Cambridgeshire. That's a single PCN practice of 58,000 patients, and I'm chair of the board there.
Awesome. Thank you, Stefan. Next, I'm going to go to Ash. Ash, say hi to the eGP learners out there.
Hi everyone. It's great to be here this evening, and so my kind of area of focus within research is looking at the use of triage in urgent care, and so that's kind of within the out of hours setting, a little bit different to the kind of hubs we're talking about today, but hopefully there's some overlap there. And I currently work at Oxford University and Warwick Medical School.
Awesome. And finally, Phil, say hi to everybody out there in eGP Learning Land.
Hi, everyone. Thanks for inviting me this evening. I'm Phil Wallek. I'm a GP partner by background and a clinical director of Foundry PCN. So we've been working out maybe how same-day access hubs can work for the last 5 years and actually trying to make it part of what general practice is. So I think it's about making general practice better and bringing things in that we can do better, I think, rather than seeing it something that's going to be destroying general practice.
Awesome. Thank you for that. So I think probably where I'd like to start, I'm just going to go to Phil, if that's all right, to start us off, because obviously you've had a model that similar, well, actually the precursor for what I think a lot of the changes that have been talked about in Northwest London have happened. In actual fact, I'm going to switch that slightly. Andy reminded me to do this and I forgot to do it. So we were going to talk about the reason why we brought this on, which was the whole changes that have been happening down in London as part of the contract and stuff. And Andy's just brought it on there. So we covered this a couple of weeks ago, talking about this shift towards having acute hubs, very much pushed by the fuller stock take as a method for managing acute demand and changing the way that general practice in some ways operates. Yeah, I think this generated a lot of discussion. We wanted to kind of have a deeper look at it, didn't we, Andy?
Yeah, I think this was an interesting story, and obviously we don't know the ins and outs. We don't work in this area of the country, but Northwest London ICB, some of the GPs there felt that a same-day access model was sort of being foisted on them, I think, sort of reading between the lines of the article, and they felt that they were being almost forced to sign up to this way of working as it become part of a single offer. So they combined all of their sort of enhanced service contracts together, sort of meaning that they really had to sign it to retain funding that they'd had in previous years. But as part of that, they needed to sign up to a model where some of their sites would see long patients with long-term conditions, patients, complex patients, but not urgent care cases or same-day cases, and that those would go to different sites that would be called same-day access hubs. I think they tried it with a few of their practices in one area of the ICB, and then they were rolling it out to the rest. And I think there was some controversy about how it was being implemented and how the change was being brought about. And then reading through some of the comments, some of the involved were concerned about whether this would work, whether it was best for their patients, whether it meant the end of general practice as we know it, in terms of separating, minor ailments from those more complicated cases, which for a very long time have been seen together within the general practice team. So quite controversial, but really good to expand the debate away from this particular area, which we don't necessarily know all the ins and outs of, and to bring in expertise from other areas and to structure a better discussion around that this week. I think hopefully I've covered everything there, Gandhi, and orientated people okay.
I think so. Yeah, I think that covered most of it. I know that we did offer people from NWL and the ICB organisation to join us on this. Unfortunately, they're not be able to. But in their defence, we organised this with about 48 hours to go. So everyone's busy and stuff. So fair enough. But I guess, like I said, I did want to go to Phillip first, just to kind of get an idea of the way that you created the system that you guys have down in Foundry and stuff, because obviously this is was used as a precursor, particularly in the stock take, as how a model can be used to deliver care. Very much keen to hear about obviously your network, how that started, and how that journey went in terms of what you've created, really.
Yeah, so we were originally 3 different practices, and we're actually in quite a geographic location. That means we're one town, but one town with kind of 5 sites across it. So we had 3 practices, 2 were operating from their own buildings. One had a branch site as well. So we had 3 sites in the centre of Lewis and then 1 branch site in one of the villages. The kind of relationships were okay between the practices. But I was very keen about pushing forward and wanting to do something different, because I felt, the future of primary care wasn't where I was, which was an 8,500 practice. And if we were going to do things better, then I wanted to look for something which offered us sustainability. And I wanted something that was going to be that I wanted to be a part of, that wasn't just, I guess, a traditional, in some respects, general practice. I wanted to spread my wings, do something different, and use specialist skills. So I was a dermatologist as well, by background, a bit of gypsy dermatology work. So I knew that there were specialisms that held by the different GPs in the different practices that we could benefit from. And also I thought that all these examples elsewhere that we started to go out and look for, all were looking around scale, and Grantham was one of those practices that we went to look at and see, well, how do they do it? And it was the primary care home that we were using then as a model for that, which was, rather than seeing then the GP as always the front door, as a single point of access, it's trying to see the whole multidisciplinary team and making the most of the whole multidisciplinary team. So it was really about setting about how do you achieve that, but still hold on to the bits of general practice that we wanted. And that was continuity. And interestingly, the thing I think that I'm saying slightly differently is that the on-the-day access also needs to have continuity. So for those patients who need it, so the complex patients with ongoing problems, they should still try and have continuity. And I think it's about trying to have continuity whenever you can, if it's possible. So with a usual GP or with a smaller team. So this is about smaller teams of GPs and how small can those teams be and still maintain a daily access for a patient who needs the continuity. So that's what we tried to work from, and essentially said that we've got basically 30,000 patients. So of those 30,000 patients, what groupings can we have that mean that we've got those small teams of GPs? And we worked around groupings of 5,000 patients originally, which was each practice in essence being broken down into groups of 5,000. And those then were like GPs who were supporting each other, much in a way you do as a job share, where one half is working one part of the week, the other half is working the other part of the week. But with everybody doing flexible working, everybody doing other roles, maybe doing teaching, specialist clinics, other roles elsewhere, what we tried to do is try and create this jigsaw, really, of those numbers of GPs that could fit together to make that smallest number possible. And sometimes that's like 2 GPs, job sharing, but often that's maybe 3 or even 4 GPs who are kind of offset against each other with different days of the week. And those smaller teams then is what we built the model on. But then in order to work together, we needed to do something which allowed us to kind of share the workload and also make the most of the additional roles. So that's where our idea of patient streaming, the identification of those patients were, and that's what really helped. So we started off looking at read codes, and read codes being the way in which you could say, okay, and actually it was from electronic frailty index was the original model we were looking at in terms of trying to identify those patients who needed continuity because of complexity, but realized actually it wasn't just medical issues that we were talking about, it's social issues, it's those other needs that are there, substance misuse, things that often weren't coded well, so you weren't able to pick them up from a read code. So we kind of flipped that on its head. So instead of using read codes, we just asked the GPs themselves, who do you feel needs continuity? So we created a template, and that template pops up at the end of each consultation and asks the GP themselves, do you think this patient is generally well? Do you think they've got ongoing conditions that need some continuity? Do you think they're a complex patient that we really should give continuity to? And then you offer continuity to those who most need it. And those green patients, which is our generally well patients, then formed what in effect was our acute hub. So it was really saying that those who don't need continuity are the patients that we can put into one pool, and then whoever's available of GPs or paramedics, then and it, actually that's built now into a sort of mental health triage team as well that helps with that green list. So anybody who doesn't need continuity are those who get put in that pool, and then we all work from that pool. Now our GPs rotate through that, and I think that's another key part, is we're all part of one team. So we go back to our practices to do our continuity work, but then we're rotating in through the green hub in order to do that on the day access. And it's a bit, in some respects, like being a duty doctor in a regular practice. You know, you're just doing that same sort of work, that quick turnover, that kind of simple problems. But actually, you're trying to farm as much of that out as possible, which is what most people practices are doing anyway, to advanced nurse practitioners, paramedics. So it's just making sense of that. And that model then is kind of these hubs that we've got then with continuity, and then the green hub. And I think that can be a physical hub, which is what it is for us. But it also, in some respects, operates almost like a virtual hub as well. Because when you've got multiple sites, you can spread that work around.
Cool. So really interesting there, Phil. I'm curious, and I'm going to take a question, if that's all right, from my own head. Being a PCN clinical director and coordinating that, how on earth did you make that happen? Because that seems like a huge amount of work to happen. And obviously that's happened over, I'm assuming, a couple of years. Is that right? Or quicker?
Yeah, so it's really a 5-year journey, I would say, from kind of start. In terms of how, I mean, I think we all want to be sustainable. We all want to do jobs that are of interest to us, and we want to have flexible careers as well. So I think people want to progress through different things. So what we were trying to do is really offer to all of the GPs who were within our organizations, there's a way of doing that. So if we are all in that goal, we all want a sustainable practice, we want to try and maintain continuity, and we want to try and maintain income, because I think part of this was looking at what the future is going to be for general practice. And if the future is larger hubs, we want to control that, and we want that to be something that we think is the way we should be doing it, rather than being dictated to. So it's a bit about taking control and saying, yeah, we can do this.
Cool. Okay. Andy, go for it.
I'll take a question as well, if that's okay, Phil. Interesting thing that struck me there, that sounded a lot less sort of different. So fantastic work, actually, and I've already jotted down a few things to take away to my own geography to think about. Sounded a lot less threatening than I think a lot of people kind of think of when they think about sort of same-day access hubs. You know, that sounded much more like, you know, just good, normal, general practice. That was just a reaction that I had. And I was just wondering, so is it that you have is it just sort of green cohorts, or is one of your sites sort of always the green site? Because that's the impression I got reading the fuller stock take, that you had, you know, one location that was always green and the others weren't. But what's the situation on the ground?
Yeah, so I guess that's about physical location you're referring to, as to what does it physically look like. So what we did originally, our first iteration was one of the GP buildings which had, we took the top floor, which was where there was in fact, it was originally a kind of a meeting room and a kind of a lunch, refreshments room that was in the biggest space that we could find. And we took one GP from each practice and put them together there. And then that was a triage hub. So that was us doing telephone triage for the patients. And then we used a clinical room downstairs, which we then shared. So it actually also freed up some clinical space because we took GPs out of their rooms, put them together, and then it was 2 GPs per practice. So it's 2 GPs, and that's in essence kind of the most that we had in that green hub. And then registrars could come and sit alongside as well. So there was a lot of cross-learning that went on, interestingly, because it's physically located. And you were triaging together. We found actually we tried to do it all day and found that an all-day duty session doing that was actually felt a bit much. Like doing a duty session, it's quite full on, turnover that you've got lots of patients. So people actually only wanted to do half a day, then go back to continuity. So go and do an afternoon, doing continuity, switch over. And interestingly, then you do continuity for a few sessions and you think, actually, I want to get back to the green hub because I've had all my complex patients now. My head's full with all of this complexity and all of these challenging patients. Actually, a little bit of quick turnover. So that variety helped, and actually creating a team atmosphere because you are all together at times, and it changes who you're with. So over the weeks, you're always rotating through, and you're just coming across the GPs again. So when there are those challenging times that happen, when people are under pressure. When somebody goes off sick, when, so many patients come in and then this is happening. And then you've got a relationship with the rest of the GPs across all the practices that you can send an instant message to. And you say, look, so-and-so's on the list today. I see you've been involved. I would be doing this, but do you mind doing that? So it creates more of a working relationship between a larger group of GPs by bringing that green hub as being a place where we all rotate through.
Thanks for that, Phil. That feels so much less threatening than I feel so much less threatened than that than I did sort of reading the story about the Northwest London proposals. It's just really interesting how the different reaction I'm having to your model compared to reading that story. Of course, we don't know quite what they're proposing, but just very interesting. Back to
Definitely
you, Gandhi.
agree with that. Yeah. So I guess at this point, I wanted to ask Ash. Phil mentioned that obviously a few things around triaging and the concept of streaming patients and stuff. And I know you've done work along those lines and stuff. I guess, how did that sound to you? And how do you feel that looks different to what's possibly being proposed from what we know about the London models and that kind of stuff from your perspective?
Yeah, actually, I had a quick question, if I could just start with that to Phil, which was around, just from my own knowledge, really, in those green hubs, is that kind of telephone triage, is that face-to-face, or is it a combination of those?
So it's mainly telephone triage. It's not been fixed over time, and I think a big part of what we try to do is we try to learn. So we say what is working and what's this iteration like. So it's been full telephone triage for a period, and that was particularly during COVID. And so we were kind of doing this just before COVID hit. And so we'd learned a bit about telephone triage. So when COVID hit, we were kind of already pretty much set up, ready to quickly transition into telephone-only triage. And the idea was all on the day access is telephone triage. And then you bring in those who you need to. But you can pretty much complete 75% of the work that was coming in on the day on a telephone, and then only bring in those 25%. So those are the on the day work. The Green Hub has also had spaces for people to book in advance. So those would be patients who are green patients who are generally well, and they can book in appointments then up to a couple of weeks in advance. There are some appointments that we've got that are sort of 30-day type appointments. And those are ones which have actually now shifted more back into the continuity hubs. So the proactive and those kind of pre-booked appointments are now back in the continuity hubs, whereas that green hub is then focused on the day and book within 2 weeks, 1 to 2 weeks for those types of patients. And those ones can pre-book as a face-to-face. So we've got some pre-book for face-to-face, but on the day is all telephone triage. And now we're really moving into digital first as our model. So we've been doing a bit of a hybrid with digital first, for the last sort of 2 years with eConsult, and we've moved over to Anima now, and now we're about to go kind of more full on and try and do a digital first approach to bring in that as hopefully giving us more information so we can triage better.
And in terms of the triage conducted in the green hubs, is that kind of based on different staff types, or is that mainly the GPs doing the triage?
So it's actually a mixture of staff types. So our receptionists take the call. They've taken an initial piece of information. That's then on the patient record with a one line of what the receptionist feels the issue is. Also from the receptionist, what their impression of the urgency is. So that, is this something that we have to deal with really urgently today? And that allows us then to look at that list. So then we have our whole list growing during the course of the morning. And then from that list, we then are picking from the lists. And then we have sort of up to 5 or 6 clinicians, which will be 2 paramedics, 2 GPs, and then we've allowed other people at different times. So we've got first contact practitioners, physiotherapists that we take from the list as well to push into their availability. And because we know all of those patients are generally well, we know they're more likely to have a completion of their care by those other people, rather than they're going to be coming with that problem plus all the other stuff that they haven't said. So all of the other issues that might be ongoing. So there's more of a chance that they're actually going to have a completion and a good experience of care because they're seeing somebody who's competent enough to deal with their problem. And we allow those staff, those paramedics, to choose those patients so they feel appropriate.
Yeah, I think it's a really, really interesting model where you do have the kind of more complex patients separated. So yeah, in my research, I looked at telephone calls made to the NHS 111 service, and I looked at kind of how patients were assessed by that service, and then how that compared to the kind of later assessment by the clinician, and that would be kind of the kind of clinician triage, the re-triage, and I guess my main findings were that a large proportion of calls get downgraded in the urgency level. And so that kind of clinician triage, that re-triage is really essential in urgent care. And it sounds like it's a kind of a fairly similar model that you have there. And another finding was that a proportion of calls, I think it was about 12%, they actually have their urgency level underestimated by the pathways initial triage. I'm just trying to think how this kind of map onto what you're describing, really.
Well, that's quite interesting, because I think there's a point of what we're trying to experience now with digital first is we're kind of creating a model which is care navigation at the first point, which is trying to enable them through assisted kind of triage. So they're getting a bit more information because they get questions then that they should ask, which is a bit like the 111 model. And then what we're doing is we're asking those receptionists then to say what they think the urgency is, what sort of appointment they think that patient should have at that point. Then at that point now, we're going to be looking at that digital information, that's been gathered at that first point, and then just making a quick decision on it and saying whether we agree with that decision or not. So that's our first kind of step now, is going to be a learning step that hopefully then uses the clinician's knowledge and our care navigators, our reception knowledge together. Because I think they are also better than us sometimes, because I think they're actually more experienced at dealing with those first kind of point of contact information gathering, particularly if they're an experienced receptionist, and they know better about other models or other things that are going on in terms of some of the social other ways that we can access care. So if we work together, we're actually gaining the best of both, and then we're both learning from each other. So what I want to see is a learning model that tries to create actually an ever-improving triage, which uses both the receptionist and local knowledge alongside the clinicians.
So if we could bring in Stefan, in terms of your perspective of how these kind of models look and feel, both from patient, but also from the academic side, what are your thoughts in terms of what we've heard, but also what we think may be happening elsewhere?
Yeah, it's an interesting challenge, isn't it? So the question is, what do you prioritize, continuity of care or urgency? And so you can have, and I think, so from the grantor perspective, grantor medical practice perspective, I think we've learned over the last 5 years that we have maybe overemphasized acute and urgent, and we have therefore not been able to, we basically had the practice open to whenever you, if you call us before 5, we are going to see you. So we really gave preference to access. And then we realized over time that this wasn't very productive because we created more appointments that way. So that then led me to do a piece of work on 10 million consultations across the UK over 10 years, across England, where I looked at what happens if you see your regular doctor versus your non-regular doctor in terms of how long it takes until you come back to the practice. And when you see your regular doctor, your revisit interval is 18% longer than if you see another doctor. So the regular doctor really, and they don't take longer in their consultations. So the regular doctor really is able to keep you healthier and out of the practice, therefore, for longer than a non-regular doctor. And so we understand you can't provide continuity of care all the time, but we then looked at what happens if all the practices provided continuity of care at the level of the top 10% practices in England. And that would save us 5% of appointments. That's 15 million appointments across the country. Now, Foundry is not in the top 10%, it's in the top 2% or top 1%. They save even more that way. So if you really prioritize continuity of care and then think about how do you then also provide acute care in a sensible way, that I think is certainly over the last 5 years, my learning, both in practice and in looking at the research.
Interesting, definitely. And I think having that, we definitely know that, and the recent evidence as well has been that continuity is the thing that actually keeps people healthier. You know, there's lots of evidence that supports that continuity does that. But I think also Stefan hit one of the things on the head, in the sense that actually providing continuity right now is really quite challenging because of the workforce situation we're in, because of the demand that we're in. And it sounds like what Phil's setting up is trying to do that based on team-based continuity rather than individual clinician-based continuity and things. And I know that's something that's been modeled in other areas. We've got quite a few questions coming in. I know Andy wants to jump in on something as well. But if I can, Phil, can you just give us a brief kind of synopsis of how that team-based continuity seems to work differently?
Yeah, so I think that's one of the things that we've wrestled with, really, which is how do you create continuity with part-time GPs? And how do you produce continuity with trying to balance acute care, urgent care versus proactive care? Because you can't do it all, and you can't have it all. So you've got to balance things somewhere, and you've got to create compromises somewhere. And what are those compromises, and what do they become? And I think we'll never create something which is perfect. I think we've got to do is you've got to use data. We've got to look at that. So we're very much about looking at data, about what are continuity metrics that we can use in terms of saying how well is that working for continuity. I don't think it's as good as it could be, because I think what team-based continuity does is it does keep it contained within a team, but could we do better to try and get them to the same doctor each time? Now, the problem is if you're always responding to people as quickly as possible, by definition, you're removing continuity. Yep. So you kind of have to say, no, sorry, you can't come in now. You have to wait. So that my hope is with the digital first approach, we can try and offer more appointments further away and get patients to choose into the right one and see there's a value in waiting, because I can get the person that I think I should be seeing rather than be giving the next person, even if it's within my team, because we can give continuity by team within a group of 3 or 4 GPs, and we'll keep coming back to that. But can I do better? And I want to try and keep doing better. And I think we're getting there. But what we've had to do is create a model first, and then create a data set, and then look at how you build your teams, and then look at demand and capacity analysis in order to properly understand who's trying to get appointments, when, for what, and then try and shift your model as you go in order to bring those teams together and then try and create those right points of access. I think we're getting there. I don't think it's done. I think there's a lot of learning that we can still do.
Phil, can I just come in on this? I think one of the main challenges with potentially models like the Northwest London model is it creates confusion with patients. Patients don't know where to go, they don't know what to expect from whom, and so on and so forth. So unless it's very clear to patients what the job is that we do, it creates confusion and therefore inefficiency. How do you communicate your model to the patients? Do you need to, or is it very clear to them? Is there anything you do on that side?
I think we fell down a bit on this during COVID. We did a fair amount of comms leading up to the change. We did lots of patient engagement. We did loads of meetings. We were kind of explaining all this idea of continuity. The problem with COVID is everything then got kind of thrown in as to what's going on here. We also shifted patients in order to try and create a better team. So in our branch site, what we wanted to do is we want to say all those patients who are around that branch site, we think you should all go to the branch site because we've got a group of GPs that can provide continuity for there. But that meant actually saying that those who used to go to the other sites, actually we'd rather you go here now. And that also came in COVID. So we kind of had this kind of, nobody quite knew what was going on. You know, are these changes because of COVID? Or are these changes because Foundry has done this and they've asked us to change? I mean, us change which practice we go to? How can I think about that? And I understand that because, you know, you have a real kind of loyalty to the people and the building that you've been going to. So actually asking people to change that. So we've then now gone right back into lots of patient engagement, bringing them on board, patient involvement in the design of the process. And they're very much on board with this kind of now our next iteration coming to digital first.
Right.
Cool. Thank you. I'm just going to do a couple of quick nuts and bolts questions, if that's all right, because we've had a few come in from the chat and stuff. So just to understand the model a little bit clearer. So Rob Owls has asked, are pharmacists in the Green Hub? It sounds like you might have some. Is that correct?
So we do have pharmacists. We've got pharmacists and pharmacy technicians. What we actually tend to do is they're not strictly part of the Green Hub because all of that work, which is medicines related, is filtered off before it gets to the Green Hub.
Okay.
So that's kind of pre-triaged. And so then we have then queries that come through to our pharmacy team, and they work as a team together with our prescription clerks, pharmacy technicians and pharmacists.
And I'm definitely curious to know the answer to Sanjay's question. So pharmacy first. Has this been helpful to this kind of model, or is it a disaster in waiting as he's modeled it? I guess it's a different way of doing things in terms of acute care, isn't it?
Yeah, I mean, so we've been doing some work. I mean, what we've actually done is really create everyone who's much more mindful about the patient who's contacting us about what their problem is. So our receptionists have actually been very good at starting to train our patients into simple problems going to the pharmacy first anyway. The big issue relates to pharmacies also go through challenges of are they busy or not? And some have been through some really tough times with changes, handover between organisations for pharmacy, and then everything falls apart. So then you're back to them coming back to you because there was somebody who was good there, now there isn't. So there's this constant kind of having to work together at it. So there's a lot of kind of managing relationships and knowing what's going on in their organisation as well. If you're going to say there's a reliable place for them, for the patients to go to. So it's hit and miss, I would say. It's really good when it works well. And I do think it's a good thing. I think there are challenges within it though.
Definitely agree with that. So Sarah comes in with, so Sarah's random stuff, interesting name there. How do you see the personalised care roles, SPLWs, care coordinators, health and wellbeing coaches fitting into these models? Can they provide additional continuity of care role within the SDA hubs? Not quite sure what an SDA hub is, but go for it.
I guess that's the same day access. Yeah, absolutely. They are, you know, absolutely critical, I think, to how you can do both the acute and the proactive care better. So what we're trying to move to a model of that our complex patients, the complex lives patients, they should be accessing our service through a care coordinator. So not just a care navigator, they should be coming first to a care coordinator who can then decide, is this an urgent or social issue, or is this something that needs to go elsewhere to another team, or is this something that's a medical need? And because they're a care coordinator in a specialist area, so we've got dementia care coordinators, palliative care coordinators, then they're able to give a much more meaningful response to that patient and really improve the access for those complex patients. So I think they're absolutely key to it. Social prescribing is then where you then access those other services for proactive care. So through care coordinators, through care navigation, that we should be passing off so much more in that direction.
And then I guess the last one I'm going to take from the kind of the comments and stuff. So from Anish, and this will lead into, I think, some of the stuff we've heard from NWL. I can see how this would work for a practice that's also a PCN. Not sure how this would work in a more fragmented PCN itself. I guess any lessons?
Can I just jump on that as well, because I think that's at the heart of something I was wanting to ask at as well. So good comment from Anish. I think what he's driving at is, some might say, what you're describing, sounds very much like a well implemented on-call system with, at the scale of a large multi-site practice, and actually that might be what we're seeing here, and it's really implemented really well. What other areas are looking to do is sort of take the learning from what you've done, but implement it in much more complex scenarios. So across PCNs where they have lots of different practices, and I guess in some areas relationships might not be that well established between different practices and with the ICB, who are now the people sort of pushing forward with this. I was just wondering how applicable you feel your model is outside of that single practice, single PCN situation.
I mean, I think regardless of PCN or practice, this is size. So it doesn't matter whether you call it a PCN or a practice. I think this is having a size which enables you to do that. I think at a smaller scale, you can do, it's good to know your red, amber and green patients. It's good to know who your generally well patients are, who your complex patients are, and who need some continuity. So then you can organize things better within your practice. It might not be the same way that we do in terms of a central hub, but I think there really are opportunities for practices to work together at it. So I think as a group of practices within a PCN, it's a way of actually encouraging working together in that PCN, because it fosters that you're working together at something, and it can produce resilience between you. Because I think this is about risk. And about how many people are going to be off sick on any given day. You don't know, who's going to have the practice where somebody hasn't turned up today. So how can we support each other? So you can get on with that by yourself, and that's fine. Get on with that yourself. Or how about working together at it? Now, my opinion is, if we can show that we can do this at scale, that's where we're going to get funding. Because actually, the acute sector wants us to do more urgent care. And they know that we're more efficient at dealing with those patients. The money at the moment is going to UTCs and A&Es to provide their service. They want to send it back to us. Now, I think we need to give them a consistent approach that enables the funding to flow to us, so that we can then show that we've got a consistent approach to dealing with urgent care. And if we can do that, then actually it's going to be better for general practice as a whole, because I think we do it better. I think we provide so much better. We can manage risk better, so we're able to understand that better as GPs, and we can bring people back. And I think that's one of the key things. We can see somebody and say, I'll see you again on another day if I need to. That backstop is there. So I can reduce the numbers of contacts you're having because I'm managing your risk with you. So I think that's what the real benefits that we've got. We need to maximize that. And if we don't, the money will continue flowing into A&E.
And if I can use that example, and be keen to know also Stefan and Ash's perspective on this afterwards as well. One of the comments about the whole kind of acute versus chronic split is this whole prospect that sometimes patients attend with what sounds like a very trivial acute issue. There's a deeper seated kind of health concern or issue at the bottom of that, where actually it is more complex, or continuity is actually quite valuable, those kind of challenges. What's your experience of how those kind of situations come through, progress, and then also get adapted? Because it sounds like your system has a way of making that possibly adjust afterwards. But that may not be as easy to do in, I guess, a more fragmented model. You talked about the template and stuff. I guess that's what I was thinking. But there's a lot there. Apologies, but hopefully that came through okay.
So you're saying about simple problems turning up with otherwise complex patients and what else they might be bringing to the table at that point.
Yeah, so I guess the hidden consultation, that we always think about, and things. But also, how have you, over the time that you've tried this, how have those particular consultations changed the way that you've done it?
So I think thinking from a continuity perspective with complex patients, you kind of expect them to turn up with something else. So they're going to present with something small, and there's always going to be a list of 5 other things. So hence, it's longer appointments. That's always there for those patients. Now, for those green patients, because I think there's a place when people transition from, I haven't got any complex problems at the moment. I'm a generally well person, but I'm about to become a complex problem because I'm about to find that I've got a cancer diagnosis, or I'm about to be seriously mentally unwell. There's something here that's and this is my first presentation of me coming with this, and I might be coming because of what was said to be a sore throat, but look what it ends up becoming. Now, I think there's a couple of things to think about within that. So one is about if that's you as a GP, and if that was me and a Green Hub doing that, I know I can bring that patient back to my continuity afterwards. So there's an ability for me to bring that patient with a journey back with me, and I'll label them at that point as being then an amber patient who needs continuity. Or if it geographically doesn't work, I can identify them at that point and say, look, I can do the first couple of steps here, but in terms of you, I know that you're going to need continuity. I'm going to pass you on to my other team who I know then can provide that for you. If that's not a GP, though, who's got that consultation, so if that's a paramedic, if that is another clinician who doesn't have the depth of knowledge or to deal with that complexity, I think that's all about supervision. And there was a mention there in the comments about supervision. So this is about each patient still having a GP who they has as a usual GP. So there is a line of responsibility, accountability. So if there is another clinician who's seeing, they know who they can come to, and there's a direct link to somebody who's going to take accountability for that patient. And what that does is that produces supervision for that ARS role. They know who they can come to, they can ask that question. And so then we've got this very open approach that really means that those ARS role flourish because they know that they are being supported in what they're doing. And if there are complex patients, we're actually helping them, and they're growing them as their role as well as being supported. And the patients then feel supported because we're all working together as a multidisciplinary team.
Cool. Ash, any perspective, I guess, particularly from some stuff you've done in terms of that particular aspect of, the hidden consult, the more complex initiation kind of stuff?
Yeah, I've done a little bit of a qualitative work on in the urgent care setting more so. But what was quite clear is sometimes patients will call about something, and they'll have a clinician sometimes come out to see them, and they'll find something else that was wrong with the patient that they didn't think of to communicate. So that's something, I suppose, more to do with telephone triage and the potential to miss problems. And potentially miss patients who are a bit more complex than what they've communicated.
Cool. Thank you. Stephen?
Yeah, I'd like to comment on the commercial side, the stuff that Phil has just mentioned in terms of what's the offer to the system. I think that's very important because we've just had the new contract released and it doesn't look great. So practices will be under ever more financial strain. We'll have to think about, are there other ways to get funding out of the system by solving some of their problems? And this brings me back to this notion of the single PCN that Andy and the commentator had brought up. Can this work in a more complex context where you don't have a single practice PCN? I agree with Phil. It can work operationally, but you will not so easily be able to make an offer to the system that is credible, that is repeatable. No hospital, no ICB or so is interested in having 50 or 100 different contracts with 50 or 100 different practices. So somehow we'll have to be able to have 10 or 15 PCNs that come up jointly with a credible offer, and then get money flowing by solving a problem that the ICB has, either on the health inequality side or on the acute side or on whatever other side they're burning money in, where primary care and general practice can do a much better job. This is, I think, the challenge on the commercial side. This is where single practice PCNs really have an advantage. We are at the scale that you can go to the system, and the system then begins to talk to you. Phil, I'd be very interested in your comment on that.
Yeah, I would absolutely agree with that. I mean, I kind of feel that we're in a stepping stone place at the moment, which is PCNs working together. What does that look like? From a personal perspective, from a kind of a risk perspective, me as a partner is about, well, if I'm going to share stuff with these other guys, you can go so far, and we did go so far without merging financially. We did a lot of, we got to that kind of PCN-ish kind of model of, we'll share a bit of staff, we'll share a bit of nurse, we'll share a bit of management, and that's fine, and it goes so far. But then you're just doing this whole relationship part of trying to keep everybody happy the whole time, because everybody fears that you're taking more than them and you're taking more than them, and how's that? And at the end of the day, I think the only way you that works for you financially and risk is to get in, and you basically just have to say, yeah, we're going to do it, because if we're going to make the benefit out of it, we're going to do it in that way. So I think that's from a partner perspective and that perspective. From the system perspective, absolutely. I mean, we've got to, in some respects, stop thinking about ourselves, about the problems we're solving for ourselves, and we've got to think about the problems we're trying to solve for the system, because that's the way the money's going to flow. It's not because we're saying we need this, we need this, we need this. It's what does the system need? And we can answer that. And I think we can answer that.
Absolutely.
Andy?
Okay. Yeah, I was just going to, so one comment, one question. So one was just on this, the issue of the ease with which this might be implemented in other environments. It does strike me, and I do worry about how much more difficult this would be to implement in a PCN that isn't a single practice. Just thinking about PCNs I've had contact with and the level of relationships between different practices and trust. So I do have a question mark about how applicable it is in different environments, but I think it works very well in the right environments from what I'm seeing. The other was just a question for you, Phil. So obviously you were featured in the Fuller stock take. There's been quite a lot of interest in the model that you've been doing at your primary care network. And I just wondered, have you had any interest from your ICB about moving some funding from the the hospital trusts and their acute care services to do more of what you are doing, because you're at the vanguard of this sort of work, and if anybody would be getting interest about funding moving, it might be you. Are any of those conversations happening?
So I think this is the problem. If you are a vanguard, you're out by yourself. Now, ICBs don't want to give money to one person doing one thing, because it's just not, for their mind, sustainable. So what's the point in them? So in effect, we've been a pilot in terms of, we've been working alongside the UTC. We've been supporting them. We did some cross coverings. We got paid for that differently. But to get to the next step, you actually need a whole group of people doing that together to be able to be the place that A&E can now ship stuff out. And if it is only one of you, it doesn't work. So that's why I'm feeling that actually what we want to be able to do, what we should try and do, is to try and produce some standardization, some consistency, which may not all be the same. And, and I don't expect everybody to be doing what we're doing, but enough of it that means that the system can see that we're going to be doing something positively for them to offload work. And I think that's the hard thing, because in essence, what you're saying to your GP partners is, we should be doing more. We should be seeing more patients. We should be making more contacts with patients. And that's what we should be doing. So let's encourage more work to come our way, but it's work that's paid. So let's grow our workforce. Let's grow our organization, and let's try and do more.
Are there other neighbouring PCNs to you, Phil, that are interested? It feels like you might have the opportunity to create some critical mass if other people came on board nearby. How is it going down with people in your area, so neighbouring primary care networks?
So I think a lot of people have taken different elements of what we've done. So loads of people have kind of taken on the RAG, the streaming of patients. I think there aren't many other practices, so there aren't many around us who are large enough or have gone through that transition yet. So those that are interested and are starting to do elements of it, and it is having this ripple effect. But it takes a long time. You know, this has been 5 years for us to get to that point, to gain trust, to build relations, to go through a transition. So it will be a little while longer, but I think people are getting there. So that, you know, we are starting to work with other practices in order to look at the ways in which we've done it and try and get them to take it on board. But it's bit by bit, and I think it's slow progress at the moment.
So if I can, Phil, mindful of the fact that from what we know of the NWL model, it's happened within the past year or so. Obviously, they're mandating that practices move towards a similar model to what Foundry have done, but not the same model by the sounds of it as well. Do you think that's a good way of moving forward? Because it sounds like they're trying to do it at scale, which is what you suggested, but it doesn't seem to have had the same level of engagement from my knowledge. And also part of the challenge is they've mandated it by linking it to the funding, which the practices can't effectively go without. So it's an either or kind of situation. I'd be keen to know your perspective from that point of view and in the implementation of it, shall we say?
Yeah, I mean, there's always pros and cons to each side, aren't there? If you just let things try and evolve on their own, then do they get there in time? Some standardization, and actually there's a carrot versus stick. So should they be offering more money? And if we were in a different financial environment, maybe that's what would be happening. So if we were in a growth environment, probability is more money would be coming out, and then that would be something that would encourage people into the right place because you'll get paid to do more. I think the ICBs are stuck because there is no more money. So they're trying to do this at a time when there is no more money. So they're stuck trying to then encourage people into the right direction. I think the mandating part is difficult because I'm not sure that's the right way to approach it, because everybody has a different perspective on this and they can't suddenly change their whole operating model in the course of 1 year if they want to get to that. So I think there may be different levers to push without it necessarily being mandating removing all of the funding.
I must admit that's the part I found most tricky to understand with the model that NWL seem to have suggested, it in the fact that obviously practices have built themselves to have parts of the practice that deal with acute, parts that deal with chronic, and then suddenly having that shift away. What do you do with those staff members who are now almost in each individual practice don't have any work to do because it's shifted to a different place by different, and theirs seems to be very much a different team, whereas yours is taking the practice-based teams to do both and switching between. So there is that continuity, but also that acute. Whereas this is everything goes acute one way, and then it sometimes comes back to you through the chronic. That was my understanding, which I appreciate is reading the text rather than living it. And
Andy, can I just ask Stefan, because just before the soft start, we were talking about taking models that work well in one area and applying them across to other areas, and I just noticed you sort of reacted a little bit as we were talking there. Did you have any thoughts about that issue of almost of implementing it in this way? What were your thoughts?
Yes, no, I there's no silver bullet. There's no money in the pot. Tell me why this would work better. So I think, okay, I'm a big believer in the Foundry model. It works for Foundry. It probably would work at Granta if we wanted to implement it, and maybe we should, and maybe we will. It is not something that travels very lightly. And if there is we're living in a complex system, and if there's any definition of a complex system, it's a system that you make a change to, and there will be guaranteed unintended consequences. And that's my worry about this. So you make a change to an ICB, to 80, 90, 100 practices or so. some of these practices will be very good, and they will be destabilized with a situation like that where money flow changes. And I'm very worried about this one-size-fits-all thing. So if it's a choice, as Phil said, that's a different matter. But if it's a stipulation, I'd be very worried about it.
Okay. So I think at this point, I'd like to thank both everyone for joining us. I'm aware time's ticking on. Believe it or not, we've been talking for almost an hour on this topic and things. And we've still got some other stuff we need to cover, including, as Stefan mentioned earlier, we've got a new contract, which is pretty seismic for general practice in terms of what they were looking at and things. So I'd like to thank Ash and Stefan for joining us at this point. Really enjoyed the discussion, and absolutely, people have other comments I want to stick in, do feel free to do so. I'm going to feed back to both of them afterwards, after we finish the session and stuff. I think Phil said he was going to stick around for some of the extra bits that we're going to talk about, in particular QoF and things. So just wanted to thank both of you for joining us for this section, and thank you for spending your time with us as well. I mean, it's almost 9 o'clock on a Thursday evening. That shows amazing commitment to the understanding of general practice and stuff. So thank you very much and things.
Thank you.
Yeah.
Thanks, both.
You.
Thank you.
Right.
Cool. So we did say we wanted to talk about some other stuff as well, and we're just going to jiggle the screen around because it looks a bit better that way. And interestingly, really quickly, as I like to call it, it's the end of year madness that starts officially tomorrow. So last month of general practice in terms of the financial year, QoF, IIF, it's all kicking off and things. There's absolutely stuff that I think practice need to focus on. Rather interestingly, I think a lot of those discussions may change with the contract letter, because one of the big things that's being suggested in that, and here's some spoilers, is that QoF is going to change. In particular, IIF is going to change quite significantly. But if people do want help and resources with that, feel free to check out some of the stuff that's come out from friends of the channel. So Ardens, Primary Care IT. And if you want some links to those, I know they've got loads of webinars to help practice tick those lovely boxes and things and stuff that exist and things. I guess, Andy, what's your number one thing that you need to focus on before the end of the year?
Oh, gosh, you put me on the spot.
I have. And Phil, I'm coming to you next as well, so maybe you want to think on it.
I'm just thinking about, we had a look at our QoF registers earlier today, and there are a few things that we're not focusing on because we might cholesterol indicators, things like that. It's interesting, isn't it? How you maximize your treatment. You've got to be careful where you put your efforts, I guess, because it's important that we meet our targets, but it's important that you maintain practice funding, because that's what keeps the lights on and pays for everybody's wages going forwards. We need to get some dementia reviews done in care homes before the end, because we've got about 400 care home beds, and we need to get through them. So no, that's the primary care network. We've got about 100 in our practice, so we need to get through those. I don't know. How about you, Gandhi and Phil?
I'll pass over to Phil first.
I think the top of our list in terms of things we've got to crack through before the end of the year is SMI reviews. It's always been a challenge getting them in. Those DNAs are just a killer for SMI reviews. Trying to get them, despite care coordination, that's still always a challenge. Actually, it's as much about learning this year for next year. So what now is about learning to say, what hole have we got ourselves stuck in? How can we better plan our workforce? And let's look at the things that we can start doing earlier next year to get ahead of it.
Yeah.
Definitely.
How about you, Gandhi? What are you focusing
on? So SMI reviews definitely high up on the list, given the population I look after and stuff. Learning disabilities reviews as well. So I think it's one of the things that we probably leave towards the end because it's a bit more challenging. But actually, we inevitably get them all done right before the end of the year. But I think because we do it every year towards the end, that's when we get the alert that that's when you need to do it. So then you're like, oh no, we're back in this situation again. And how can we shift that a little bit better so that hopefully it doesn't end up to be that mad rush and stuff and things. I'm aware coding wise, there's loads of stuff that comes out at this time of year about miscoding, various other kind of things. And I guess that's why I mentioned, definitely speaking to some of our colleagues out there. And so Ardens, Primary Care IT, that kind of stuff to have a look at how they can help you do the coding. Because let's be honest, a lot of this comes down to have you use the right code. It's not necessarily have you done the work, it's the coding and that kind of stuff and things that comes into play. And stuff. And interesting, we've had comments about the cholesterol one, which was a big one that I know many people were, how are you managing that? Does a 90-year-old need a statin and stuff? Well, let's be honest, they probably don't and things. I know one that we've kind of resided ourselves a little bit to, the flu vax is definitely the vaccinations ones is a challenging one when you work with a mobile population, because the reality is you just don't tick the boxes because they're out of sync more than anything else and things. But yeah. Comments from the group. So we've got Sarah, random stuff, looking at double checking max points to those income protected as well will affect next year's income as well.
Very tactically astute.
So you're probably wondering why she mentions that. And if you haven't read about the new contract, well, a lot of the register QOF stuff are going to be income protected for next year as they reconcile those to allow for less potential bureaucracy. And we heard that this may be the direction of travel in this stepping stone contract that we're being offered. Really interesting in terms of a lot of the aspects that have been discussed by the contract mechanisms. And if people do want to check out our stuff that we're going to do on that later on, absolutely feel free to do so. This is interesting on a dovetail of the fact that from the 7th of March till the, correct me if I'm wrong, Andy, the 30th of March, I want to say, is the referendum by the GPC.
Yeah, 7th to 27th of March, BMA will be holding a referendum on the contract with GP members. And I know that Katie Bramall-Stainer is really trying to encourage people to sign up to the BMA so that they can vote. And that will help them have a bigger mandate, I guess, as our trade union in negotiating this contract on behalf of GPs. So that's interesting. Declaration of interest. I'm a member, so I'll be voting in that referendum, and they certainly want people to join to strengthen their hand in negotiations with the government.
Definitely a member myself, and I guess this is probably a good point for us to briefly talk about the new contract. I know many of you probably still are here waiting to hear about this. So just to run down some of the big changes, the headline stuff. So in there is a 2% pay rise for general practice as a whole in terms of the funding that we get. That's factored in based off the cost envelope that Department of Health have given to NHS England to do. Hearing the earlier webinar from Dr. Amanda Doyle, very clear. That's the envelope they've been given. That's all they've got. With that, they have done some shuffling. So as we mentioned, the incentive-based work. So QOF has been protected in some aspects, particularly with the registers and a few of the other criteria. I think 32 points in total. IAF has been will be reconciled down to only 2 criteria. So the learning disabilities and fit cancer testing ones, whereas the other ones will be rolled into the capacity and access implementation. The CAPE funding. I've forgotten what the I stands for now. And out of that funding, 70% will still be given to practices straight away. The remaining 30% based on achievement of the modern general practice initiatives, of which it's the telephony, online consultation, and triage stuff. There is some other interesting stuff in there, which myself and Andy will absolutely be going through in more detail on Saturday.
Yeah, join us on Saturday. What's your big take home, Gandhi? What do you think is the big news in that contract, and Phil as well, for that matter? If you had time to
Phil, have you actually had a chance to read it? Bearing in mind it came out 24 hours ago, so the answer can be no.
The letter, I don't think.
Yeah, no, I've had a read of the letter. I was just trying to digest it actually and try and make out what those. There's a lot of subtleties in terms of little changes there, and are they actually going to make that much of a difference or not? It does seem to be that they're kind of removing a lot of the smaller targets within things, and that's both for the access part as well. I don't know whether I haven't had a chance to kind of digest that and say, are these things actually practically going to make a difference to me? Or all of these just little things actually not really going to make much of a difference at all? And it's really just static. That's kind of what it feels like, is that they're all minor little things and aren't really going to make much of a difference.
I know the thing that most people look for is the value increase in the contract. We can change some of the rules around the edges, which I think is what's happening here. A bit more freedom for spending of hours, money, but not GPs and not standard practice nurses. removing QOF and IAF indicators, you know, and you know, just paying the money straight through for those items. But actually, the value of the contract's not going up very much, which I think is what people are really have their eye on, and I think that's the thing that will really make a difference. So I was a little bit disappointed, and I'm not sure it's even 2%. Actually, I think that's a sort of a staff increase, including GP principals of 2%, pending review by the Doctors and Dentists Review Board, you know, later in the year. So they're kicking the can down the road with that. But I think actually, because the whole of the contract doesn't actually cover staff, I think I've seen in some articles that it's actually just sort of a 1.7% increase in actual terms, in terms of GMS. I don't know, correct me if I'm wrong, Andy. Maybe they said something different on the webinar. I wasn't able to make it.
They did give the exact figures. I think it's just under 2%. So it may be the original perpetuated 1.9%. But you're right that there is some there's some tinkering in there on certain things. Interestingly, Phil, apparently our job gets easier because it gets reclassified. So the only thing we have to do is now just make sure the networks work. Apparently,
easy job. Yeah.
Yeah, definitely. And they're reconciling a lot of the enhanced, what do you call it? The enhanced services around that, so that it's, instead of it being 8 different criteria for the PCN DES, it's just going to be one big one, and the enhanced services one, because that's still going to be separated from the others. But there is some really interesting subtleties, as Phil mentioned, that there's a mention of continuity. One of the lines is absolutely about a continuity marker, which they haven't put in detail.
We don't know what it is yet, but
yeah, we don't know what that is yet. It's not detailed in the letter or in the annexes. So yeah, even Andy and I have gone through the annexes and stuff. There's some interesting stuff in there about performance lists as well, which I think everyone's missed out, to be honest. So if you want to find out what that is, you will have to join us on Saturday as we go through in a much deeper dive, look at every single line of the contract letter and stuff, and hopefully help prepare you for the decisions about what the referendum's going to be from the GPC. If you want to check out that episode, that's going to come up right here. Alternately, if you're really, really bored or really interested, you can watch my watch-a-thon of me actually watching Amanda Doyle talk about the webinar and commenting it as we did it right here. And as ever, we'll be here to tech enhance your primary care and learning. Thank you, Phil, for joining us. Really enjoyed it. We will absolutely catch you all on the next episode.
Thanks, Phil. Got some pointers to take back to my practice.
Definitely.
Thanks.